Assalamu alaikum. What to do with Stensen's duct in parotid surgery? Identify and dissect the duct, preserve it or ligate it or re-implant it. In this lecture we'll discuss Stensen's duct injury in parotidectomy, starting with Stensen's duct surface and surgical anatomy, the Van Sickels classification of the site and the type of parotid duct injury, how to do a primary duct repair, what to do if the two duct stumps cannot be sutured, what to do if the injury is not recognized during the initial surgery, how to deal with complications, the Sialocele or the salivary fistula or strictures, managing it either conservatively or with Botox injection or with delayed surgical repair, and finally the decision making during parotid surgery. The surface anatomy. There are numerous ways of describing the surface anatomy of the parotid duct. The two commonest ways of describing this are this red line, which connects the lower part of the tragus to the midpoint of the philtrum of the lip. And the second line is the blue line, which again connects the lower border of the tragus to the corner of the mouth. It's now recognized that the red line is perhaps a little bit higher up than the actual position of the Stensen's duct, so that most 94% of the individuals will have their duct much lower than the red line. This was the commonest surface landmark of the Stensen's duct. It's perhaps more applicable to use the blue line connecting the lower border of the tragus to the corner of the mouth, knowing that about 93% of individuals will have the actual duct within 1.5 centimeters, 1.5 centimeter from that line. So that's a more applicable surface landmark, the blue line. The duct would open orally opposite the second upper molar tooth, or between the first and the second upper molar tooth, somewhere here. This will be its surface landmark. So these are two of the three commonest lines. And the third line is this, the purple line joining the angle of the mandible to the outer canthus of the eye, and this would mark with its intersection with the blue line the area where the duct actually starts over the masseter muscle. So these are the three lines, the red, the blue, and the purple. And we know that within 1.5 centimeter from the blue, in more than 90% of individuals, 93 or 94%, you will find the duct itself. The saliva draining system of the parotid gland starts in the deep lobe of the parotid and receives ductules from the superficial lobe and later from the accessory lobe of the parotid. These are duct system within the parotid itself. At the anterior part of the gland, Stensen's duct starts at the anterior edge of the gland and travels over the masseter muscle almost horizontally, and then after 1.5 centimeters from the end of the masseter muscle, it pierces the buccal pad of fat and then pierces the buccinator muscle and travels diagonally under the oral mucosa to open into the parotid papilla over the second upper molar, or between the first and the second upper molar tooth. That's the course of the Stensen's duct that actually starts at the end of the anterior end of the parotid. On the surgical anatomy of the Stensen's duct, starts after identifying the anterior edge of the parotid gland. This is where the duct starts. There are several important structures around it. The most intimate would be the accessory parotid gland, which can lie over or beneath the parotid duct. And then the duct itself would always be inferior and parallel to the zygomatic arch in very close proximity to three branches of the facial nerve that lies a little bit lateral plane to the duct, but they all course parallel to the parotid duct. These are the lower buccal branch, the upper buccal facial branch, and the zygomatic facial branch. These three branches would lie in close proximity to the duct, and they are always parallel to it. Sometimes there will be some anastomosis fibers, neural fibers between the lower and the upper buccal facial branches that would overlie the parotid duct, being in a more lateral plane. The other important structure would be the branch of the facial artery. This would just run horizontally again. This zygomatic branch would be again parallel to the parotid duct and parallel to the facial nerve branches. So the main landmark would be that it would be inferior to the zygomatic arch and parallel to it, starts at the anterior end of the gland and runs horizontally over the masseter muscle, and there will be three facial nerve branches parallel to it and one branch of the facial artery as well. How to avoid accidental duct injury during parotid surgery? A good and early exposure of the facial nerve and its branches is essential, knowing that the duct would lie at a deeper plane than the branches, but the branches would be in close proximity to the duct and parallel to it. The duct would lie about a centimeter below the zygomatic arch, and gentle traction in this area and limited electrocautery is essential to prevent any damage to the facial nerve branches and also damage to the duct itself. If the duct cannot be identified anatomically, then duct cannulation or stenting through its oral opening can be done with a small catheter or a cannula, and this would give firmness to the duct and would then be easily palpated and identified. A common classification of the parotid duct injuries is based on the site of the injury. It is quite useful because it would be helpful in deciding the management plan according to the site of the injury. The von Sickels classification classifies the site of the duct injury into three unequal parts. The site A is the largest, and this refers to the area of the intraglandular part of the duct branches and ductules within the parotid gland. And then site B is when the Stensen's duct emerge from the anterior edge of the parotid and lies over the masseter muscle until the anterior end of the masseter muscle. So the course of the duct over the masseter muscle is site B. The course of the duct after the anterior end of the masseter muscle, when it starts to pierce the buccal pad of fat and then the vaccinator muscle and the oral mucosa, is site C. So these are three different unequal sites, and the plan for the managing of the injuries would differ according to the individual site. Now the management, if it's a site A injury, this is by far the commonest type of injury to the saliva drainage system from the parotid. In almost all parotid surgery, parotidectomies, apart from total parotidectomy, the intraglandular part of the duct would be injured in one or several places. So this is the commonest. But luckily, we don't have to do much about it because there's usually very minimal uh, leakage of saliva from injuries to this part of the duct, the intraglandular part, and these leakage are very commonly would settle on their own conservatively within a week or two without any eventful complication like a sialocele or a fistula. Even in facial wound injuries, if the parotid area is penetrated by a stab wound, for example, no attempts are made at anastomosing the intraglandular part of the duct, only approximation of the parotid tissue in the area that had been separated by the stab wound, and closure of the fascia on top would prevent further complications. In site B injuries, that is to say, injuries of the Stensen's duct over the masseter muscle, if the injury is just partial, then a repair can be done after catheterizing the duct itself. But if it is a complete transaction, like in here, then every attempt should be made to re-anastomose the proximal and the distal ends together over, again, a stent, a fine cannula. If they cannot be brought together without much tension, then consideration should be given to ligating the distal end to prevent a sialocele or a parotid fistula. So these are the situations related to injury on site B. On site C, injuries of the parotid duct after the anterior edge of the masseter over the buccal pad of fat before it pierces the buccinator muscle. You can try the same. If it's a partial injury, you can try re-anastomosis over a catheter, or you can try re-anastomosis of the two ends if you can bring them close together without tension. If not, then you can try re-implanting the distal end into the oral mucosa through a small opening in the mucosa posterior to the usual or the natural opening and discard with the proximal end of the severed stump. In parotidectomy, most of the injuries to the saliva drainage system from the parotid is actually intraglandular within the parotid in site A. The Stensen's duct, after the duct emerges from the anterior edge of the parotid, is usually not exposed or identified or ligated during a classic superficial parotidectomy. And duct injuries, the Stensen's duct injuries, are quite rare, and many of these injuries are subclinical or unreported. But there are factors that may increase the risk of duct injury, including extensive fibrosis during, for example, recurrent surgery, or in deep lobe tumors that requires a wider dissection, or when there are anatomical variations in the duct branching, or in malignant parotid tumors. The risk of Stensen's duct, extraglandular duct system injury is increased. The natural healing of the parotid duct is usually quite prompt, so that if the duct itself is injured without complete transaction, it may heal if the duct injury is still partial, not complete transaction, within a week or two. And this would also happen after a primary repair if re-anastomosis of the two stumps with stenting is undertaken. And this would usually need to be confirmed by either sialography or sialendoscopy, and sometimes it may help to inject Botox into the residual gland tissue to reduce the flow of saliva during the healing phase, which usually takes between a week and two. The residual parotid tissue after partial parotidectomy or even after some total parotidectomies resume function after the surgery and the duct system heals up naturally and the saliva continues to flow. So superficial and partial parotidectomies does not abolish the flow of saliva from the operated on gland, but it may reduce it, provided that the duct is not ligated during the surgery. This study had showed that the saliva flow from patients who had either partial or even total parotidectomy is resumed within a week or so. Understandably, there will be a difference in the flow rate between those patients who have a total parotidectomy, in whom the residual salivary flow would be coming from some tissues left over from the total resection or from the accessory parotid gland, and between those patients who only have a partial parotidectomy or a superficial parotidectomy. These patients will have a much more flow compared to the group of patients who had a total parotidectomy. But in both cases, if the duct is not ligated, there will be some residual flow of saliva. The more extensive the surgery, the less the saliva, and there is a good correlation between the gland volume estimated by ultrasound and the residual gland after surgery and the salivary flow. The more residual gland left, the more the flow. Patient who had a total parotidectomy would have less flow compared to partial parotidectomy, but if the duct is ligated, as sometimes can happen during this parotid surgery, then there will be no flow at all, and this would be followed by spontaneous atrophy of the residual glandular tissue that would gradually just lose its capacity to secrete saliva. Now, what to do if the duct is injured during surgery? If this is identified during the operation itself, then immediate intraoperative management would be favorable by a primary repair. This is ideal whenever possible. You try to identify the proximal and the distal stumps of the duct and anastomose these two over a stent or a small catheter. Perhaps injecting also Botox into the residual gland tissue would help the healing by inhibiting salivary flow during the healing phase. If there is a doubt about whether there is a duct laceration or not, one easy way of finding this out intraoperatively is to cannulate the parotid duct from the mouth by a 16-gauge intravenous catheter and injecting saline through it. And if you see the saline trickling into the wound bed, then you know that there is a duct injury at the area of the leakage. It was used to inject methylene blue rather than saline into the duct, but this can actually discolor the surgical field and alter the appearance of the nearby facial nerve branches. So saline injection is actually safer. It's easy to find the oral end of the parotid stump. Sometimes it can be difficult to find the parotid end of the parotid duct, and this would require some dissection under magnification. And if there is a transaction, then anastomosis on top of the catheter should be undertaken. Sometimes it can be difficult to identify the parotid end of the duct. You would try to pass the probe or the catheter through the oral end of the duct, and the direction of the probe would usually point to where the proximal stump would be. If it cannot be identified, you can still press on the residual salivary tissue. Applying pressure on this tissue may squeeze out some saliva from the parotid end of the duct and help in identifying the divided proximal end of the duct. When both ends are identified, the duct would be catheterized, and then suturing would be attempted by placing at least 3 sutures with nylon 9O or 10O in 3 different places. The catheter would help in preventing suturing the anterior wall of the duct with the posterior wall of the opposite stump. The use of non-absorbable sutures had actually showed better results than the use of absorbable sutures. Absorbable sutures sometimes leave around some massive fibrosis and scarring that would occlude the very fine caliber of the duct. But what to do in a primary repair if the 2 duct stumps cannot be sutured, because there is a bigger gap in between that cannot be sutured without tension. In this case, you may consider using an autogenous vein graft. And this vein graft would, over the stent or the catheter inside the duct, would bridge the gap. In this case, you would need to make sure that the residual gland tissues are not going to secrete saliva during the healing phase by injecting Botox and giving the patients anti-sialogogues and also antibiotics. The patency of the duct can be checked after 2 weeks or so by either sialography or sialoendoscopy. The other options, if the 2 duct stumps cannot be sutured together, particularly in site C type of injuries, is to try and re-implant the proximal end, the parotid end of the parotid duct into the oral cavity, into a small opening into the mucosa of the oral cavity posterior to the natural papilla, parotid papilla, if there is enough length in the proximal part to reach the oral cavity. But if there isn't, then the other option would be ligation of the proximal end, and this would lead to spontaneous atrophy of the residual parotid tissue and prevent the formation of a sialocele or a parotid fistula. But what happens if the diagnosis of a duct injury is missed during the surgery and would only be diagnosed after the surgery by a week or 2, when there is a collection of saliva in the operative field or a leak of the collected saliva through the parotid incision? A collection of saliva in the parotid area after parotidectomy is usually termed a sialocele, and it would typically take about a week or 2 to form, to have enough saliva in it to be diagnosed clinically. If the saliva can find its way to the outside through the parotid incision, then it is termed a salivary parotid fistula. The prognosis of these 2 problems would depend on the site of the injury. If it is within the residual gland, then it usually is self-limiting and would heal with conservative treatment. But if it is in site B or C of the Stensen's duct, then some form of management would be required. Also, the prognosis would depend on whether the duct is completely transacted or only a partial puncture of the duct. How do the fistulas and sialoceles form? Except in total parotidectomy, when all or almost all of the parotid tissues are removed, there will always be a cut surface of the parotid gland from which saliva can leak. Salivary fistulas or sialoceles can occur in up to 10% of cases of superficial parotidectomy. The real question is why salivary fistulas are not more common in practice. We don't know the answer. We only see about 10% of the cases, not all of the cases of superficial parotidectomy, despite having a cut surface in the parotid gland. The saliva can form a collection of the sialocele or a leak from the incision like a fistula, and this usually takes within few days from the date of the surgery, not immediately when they have a sizable collection to be detected clinically. The collection can be aspirated aseptically, and then the diagnosis can be made. And the aspiration may need to be repeated several times in order to prevent the saliva from collecting every now and then and help in the healing. If it is leaking through the skin, then appropriate dressing of the skin incision would need to be very carefully undertaken, and maintenance of the wound hygiene to prevent the wound edges from infection, and antibiotics should be considered. Are the management options? Conservative management is usually undertaken first, and most of the cases would settle with conservative management of aspiration, sometimes repeated, and pressure dressings, and helped with anticholinergic agents like hyoscine patches and modification of the diet to reduce salivary output. The other option, if the conservative management fails, is to inject Botox into the residual parotid gland tissue, and this will reduce the salivary secretion and promote healing of the glandular drainage system. If this fails, then you are only left with delayed surgical repair with microsurgical techniques to either anastomose divided ducts or graft it, or even divert the duct flow through creating a window posterior to the natural drainage site in the oral cavity. If conservative management fails, the next thing to try is Botox A injection into the residual parotid tissue. Preferably, this is done under ultrasound control, where you would identify the residual parotid gland tissue and the duct itself. And by using the ultrasonography, you try to avoid, if it's a color ultrasonography scan, try placing the needle into any nearby vessels, and there are several of these, and also strictly placing the needle into the residual parotid gland would reduce the chance of injecting into a facial nerve branch. The usual dosage would be injecting of 0.1 to 0.2 milliliter of a solution of 25 mouse units in an 0.1 milliliter. So maximum dose will be about 50 mouse units. This would inhibit the presynaptic release of acetylcholine and reduce the parasympathetic activation of the gland and the flow of saliva for up to 6 months, usually somewhere around 3 to 4 months. There would be few situations during parotid surgery when we'd need to consider duct ligation during the surgery, the initial surgery itself. This is selective ligation of the duct. It's not a standard step of the most operations, most parotidectomy operations. A decision of duct ligation may be considered in total parotidectomy when most or all of the glandular tissue removed. Ligation then may reduce any persistent salivary leakage and sialocele formation. May also be considered in recurrent parotid surgery because of the scarred anatomy and the higher risk of postoperative salivary fistula. And also it should be considered when malignancy involving the duct or near the duct, when direct duct invasion can be an issue. There may be a need for oncological clearance and duct excision or ligation then becomes necessary. And finally, to sum up, these are the decision-making process in Stensen's duct in parotid surgery. If the operation is a superficial parotidectomy or for a benign lesion, then attempts should be done to preserve the duct. If it's a total parotidectomy, particularly for a malignant tumor, and the duct may be involved, then consider ligation of the duct. If there is post-operative fistula or sialocele, then you try first the conservative management with compression and anticholinergics. If this fails, Botox injection is the next step, and if this fails, then delayed surgery would be the only available option. Preservation of the Stensen's duct is the standard. Ligation is sometimes considered in selected cases for oncological or for reoperative cases. Botox injection has become the preferred minimally invasive treatment for postoperative salivary complications like sialocele or a parotid fistula. By this, we come to the end of this presentation on Stensen's duct in parotid surgery. Assalamu alaikum.